I am Hiral Bhatt. We are bringing you live STEMI India 2018 from Lucknow. Let me introduce our guest. He is consultant physician, fellow of American College of Physicians, Indian College of Physicians, Secretary API. Dr. Sanjay Tandon is there with us.
Good morning.
Good morning, sir. Sir, let me begin the questions with you. What is your view that what could be the role of a physician having a chamber practice in the management of STEMI?
See, STEMI is acute emergency, as you know that. Most of the patients who are coming to your chamber, see 60 or 70% of the physicians are doing a chamber practice. Chamber practice means where you have only a chamber, you're sitting there and doing a consultation. Now there are three important things while a patient is landing into a clinic. First, there are chamber doctors who are doing only chamber practice. Secondly, there are institutional practice where you don't have a direct cardiac, it's a non-cardiac institutional practice. And third, where you have a cardiac lab. So there are three different sets of things where a patient can land up. Now for us, most of the physicians who are practicing and doing a chamber practice, the patient coming with chest pain. In India, most of the time people land up very late because of so many problems, because of the rural problem where people don't have access to the doctors, number one. A lot of traffic congestions, people land up very late. And then, as you know, gharelu ilaj. Most of the time it is gas. Most of the time people keep on wasting time. It is just because of gas, they'll take up antacids, PPIs and milk and this and that. And by that time you waste the golden time. Now, once a patient is coming to a physician who is doing a chamber practice with a history of chest pain, once you do a ECG and you say that the patient is suffering from STEMI, the best thing, if you don't have access to anything, if you cannot thrombolize the patient in a clinical setting, then is to give him a loading dose of aspirin, clopidogrel and 80 milligrams of statin, and then transport the patient, check his whether the patient is hemodynamically stable. After giving him a loading of dose of these dual antiplatelets and a statin, then you transport the patient in block to the nearest possible a cath lab or a cardiac center, if not to an institution, for at least a thrombolytic therapy. Now, if you have facility for a thrombolytic therapy, go ahead with the thrombolytic therapy. Otherwise, the second set of patients will end up into an institute, which is a non-cardiac institute. There the best part is that since you have a hospital setting, you can immediately thrombolize the patient. Now, the people in clinical setting do a chamber practice, they have a risk of thrombolizing the patient in the clinic because they don't have beds, they don't have space. And secondly, most of the time people have benign arrhythmias, hypotension while you're thrombolizing the patient. So physicians have the inertia of not taking that risk. So best way is to give them a dual antiplatelet, a statin, transport the patient in block as early as possible to the best possible center. If it is a PCI enabled center, the best is to send them there. If not, to the nearest institution for initial thrombolytic therapy, and from there the patient can be transported for a rescue PCI to a better cardiac center.
Thank you so much for sharing your views.
Thank you.